quite a few commendations here, and most of them I think I can actually see. First one is for Dr. G and Nelson Hager, who's not here. I have to say, of the list I have here, Winston Warm leads the pack. He has 3 of them, and they are all very complimentary of Dr. Warm's surgical skills and his care of his patients. And if I just run the list here, there is one for Dr. Leopold, Dr. Matson, Doug Smith, whose patient said Dr. Smith makes her feel like she is the only patient when he is taking care of her. Dr. Tatesman, and that I think covers all of the names here. So we are going to today talk about the medical and cost effectiveness of preoperative lab testing. And this topic came about because I think everybody knows we've been asked by the administration to really look in every nook and cranny and try to figure out ways that we can save money for the hospital taking care of our patients. And I know a lot of the UWMC faculty have been involved in consolidating the equipment we use in the operating room, trying to choose less expensive equipment over more expensive equipment. One of my favorite examples of that is that the Camback suckers we use during total joint surgery cost about $40 a piece, whereas a regular plastic disposable yank hour is 37 cents. And so we have been looking, here and there. And one of the things that I thought would be interesting to look at would be just preoperative testing, because there are very strict guidelines for preoperative testing, and there's great criteria on the medical effectiveness and cost effectiveness of these labs. I spoke with some of our faculty, and someone who even graduated about 15 years ago had told me all the way back then at their hospital they would get a little pop-up box telling them the cost of every individual lab, and they would go to order it electronically. And so I thought that would be some place to look. And then I enlisted the help of Patty O'Leary Crutcher, who's been a big help with this. Amy Sizik, who has been a big help. And then Gail Van Norman, who, interestingly enough, this is one of her interests, and maybe I should say pet peeves. And so that's how we got to this point. And this is the era, they say, of big data, but sometimes maybe too much information is actually harmful. And that's one of the interesting things I think we'll demonstrate this morning. And so we're going to first have Paige Mallette present some case scenarios looking at different aspects of preoperative testing. And then Dr. Van Norman, who is a professor in our anesthesia department and runs our preoperative clinic, she's going to really do the bulk of the work here. And then I'm going to wrap it up and talk about some of our future plans and make a plea to get feedback on this so we can actually, over the next 4 months or so, put some of these ideas into action.
All right. Good morning. So just to get it started, we're going to cover some of what we're currently doing in our department, and then use some case examples to sort of detail the implications of that. Just as a brief background, most orthopedics falls into the intermediate risk category. These are patients that have a less than 5% risk of a cardiac death or non-fatal MI during the procedure. This is an elective orthopedics, and those that have a long duration or anticipated blood loss that's excessive, they actually fall into the high-risk category. We tend to order EKGs, chemistry panels, coags, a CBC, and oftentimes a Hep C serology on our patients. So our first case example is just a 64-year-old guy. He's scheduled for an elective knee arthroscopy. He has a symptomatic medial meniscus and really no other medical problems. He had been running marathons up until this recent knee injury. Just as a general question, who in the audience would get an EKG on a patient like this? No one? Thank you, Dr. Moore. All right, and if the patient was younger? No. Okay. In this scenario, the patient got a 12-lead EKG. He had some non-specific SGT wave changes, and so cardiology went forward with a stress test, showed worsening of the changes, and so they planned for a cardiac cath. His coronaries were normal, but at the conclusion of the procedure, his femoral artery was ruptured and the cordis was removed. This required an emergent surgery. He had to go to the ICU. He clotted his femoral artery and actually got a second emergent procedure in the middle of the night. So no procedure is completely benign, as it can lead to some consequences down the road. The American Family of, or the American Academy of Family Practitioners has a pretty basic algorithm for whether or not a patient needs a preoperative EKG. If they have signs or symptoms of a cardiac vascular disease, they get one automatically. But the rest of it is based on the risk level of the surgery that they're having and whether or not they have associated comorbidities. Here at the University of Washington, it's recommended for any patient over the age of 65 who's having an intermediate or high risk surgery, or if they're having one of those procedures and have an associated comorbidity that would predispose them to cardiac disease. The next patient is a 56-year-old female, planned to have just an isolated soft tissue sarcoma removed from the extremity. She's also otherwise healthy, doesn't have any associated personal or family history that would predispose her to bleeding, and isn't on any medications that would predispose her to bleeding. So in this situation, would anyone in here get coag studies on her? A good percentage. She had them done. They were essentially normal, but had a slight elevation in their PTT. Would that delay the OR for anybody who had gone ahead and gotten the panel? In this case, the surgeon requested that the labs be repeated. It took several attempts before they could get an adequate sample. The blood clotted, they had to do several more attempts, and they ultimately did get the labs back. The PTT was still elevated, and it was about 2.5 hours after the anticipated start time of the procedure. So the most common coagulopathy that they're looking at a person that doesn't have a known bleeding disorder is von Willebrand's disease. It's not even picked up on a routine coag most of the time, and these platelet studies can take about 2 weeks to get back, which is much longer than most of our pre-op labs are drawn for. And an isolated PTT elevation in the setting of a malignancy is actually associated with the presence of an anti-antibody antibody, and these patients are, as everybody knows, more predisposed to clotting or bleeding. So screening with coag panels doesn't predict a bleeding risk. Patient history and physical screening assessment is really what's necessary in order to determine whether or not one is even indicated. And unless the patient answers positive to one of those above questions, there's really no indication for a screening panel. And the reason we're talking about this is that the patients seen in the pre-anesthesia clinic, 38% of them were getting coag panels, and that was broken down to out of 100 patients, only two had an actual indication. One of those patients was being screened because they were known to be on an anticoagulant, and that's the only person that had an abnormal coag panel. So of the studies that were done in a patient that didn't have any indications, that were entirely normal and didn't pick up a single bleeding disorder. When this is broken down at about $220 per test, you're looking at $1.2 million a year just on one study in the pre-anesthesia setting. And EKGs are about the same price. So the implications of this for us is that most pre-op tests are ordered by the surgeon, and they're often done shortly before the procedure. The Centers for Medicare and Medicaid have a 72-hour rule. Any outpatient study or test done within 72 hours of an inpatient admission has to be bundled with the inpatient claim and can't be separated out for billing. So in the future down the road, when you're ordering these tests and they're at the same time as your next procedure, they're going to be part of your inpatient payment. Anyway, Dr. Van Norman will go through really the evidence for all of this.
Thanks, Paige, and thanks for letting me come and talk to you about this important topic. What I want to do is take you through a little principles of basic testing and then show you some more examples from the University of Washington Medical Center
I'm going to go back and emphasize a point Paige made, and that is that 1.2 million she mentioned, that's excess coag screening at UWNC alone. Not at Harborview, not at VA, at this hospital. Multiply that by all the hospitals in the U.S., and you might have a guess as to why our costs are running so high. So when we talk about the evidence-based
pre-op testing, what we want to think about is why are we getting the test? And we're getting the test because we're trying to improve the patient's preoperative condition by either diagnosing or detecting significant disease that we don't know for sure is there, or to optimize what we do know is there. We're trying to figure out if the patient's in good shape. And sometimes we're getting tests because we should be getting tests because we want to inform the intra and post-operative care of the patient. So we might decide on the basis of some pre-op tests to put the patient in the ICU, for example. Or the anesthesiologist may decide based on some types of testing to monitor the patient differently. What are the dangers of over-testing? I mean, it's all information, good information. I have people in my own department that think the more information they have, the better off they are, and they are wrong. You want the right amount of information. You don't want too much information. It will make you make the wrong decisions. Okay? So, first of all, a test can falsely reassure. If there's a false negative rate to the test that's significant, then you may walk away with the impression the patient doesn't have a disease, when in fact they do. Tests can also falsely accuse. You've heard the saying 1 in 20 lab tests is abnormal. We'll talk about that in a moment. But abnormal doesn't mean that a test is due to underlying pathology. Tests can lead to unnecessary further workup. You saw 2 examples here, and they're real examples of patients who were actually harmed because a test that was unnecessary in the first place led to further workup and ended up physically harming the patient. I'll tell you, just this week in pre-op clinic, we had an orthopedic case. This was not, by the way, started by you guys. Whose primary care doctor said, gee, the patient's in the right age for coronary disease. And in fact, the patient had one of those calcium scans that said he had some LAD lesions, but he's asymptomatic and could exercise well. He was slated for a spine case, or he had some spine disease. They were actually working him up for a minor surgery, a hernia surgery. So his primary care doc decided he wanted to test him further, even though there were no clinical indications for testing. He put him on a treadmill. The guy fell and further injured his back and now is having major spine surgery. That is a negative outcome of an unnecessary treadmill. He wouldn't need the surgery if that hadn't happened. So there's further expenses and complications of the workup. And why are 1 in 20 lab tests abnormal? It's simple statistics. When you look at a test, normal tests are basically within a couple of standard deviations of the norm. We test 1,000 patients. We draw a midline. Let's see right here. You draw a midline here. You do a statistical analysis and a couple of standard deviations out. You draw these lines and you say these are abnormal tests. Add these together, they come up to between 4 and 5%, or about 1 in 20 tests. Has nothing to do with whether the patient has the disease or not. It's just a statistical variation of the test. And what we assume is that if you're out here on these wings of the test, you may have an abnormality that actually indicates that you are abnormal and that you have an underlying disease, but it is not a given. Okay? Then there's also screening. I want you to understand the concept between screening versus targeted testing. We're talking about screening testing today. I order a CBC on every patient who's going to have fill in the blank. Rather than, I'm getting a CBC on this patient because they had chemotherapy last week. That's a targeted test. You know there's something that's likely to make that test abnormal, so you're looking to see if the test is okay. Today, take out of your head targeted testing. We're not talking about that. We're talking about routine testing for general population. And the general population in your case is people undergoing orthopedic surgery. We've already seen some common tests that we see in pre-op clinic that you guys order, and those of you that didn't raise your hands, I got to tell you, most of your, well, if not most, certainly around 40% of your patients are getting this test, so it's not a small percentage. Why are you getting the test? Well, I actually strongly suspect in the cases, certainly in my own colleagues, they get tests for this reason. They think they're going to avoid medical legal problems. You're not going to avoid a medical legal problem if you create a complication to the patient by doing an unnecessary test. In fact, There's literature out there that shows if you never get a test, you are much less medically legally liable than if you get the test and ignore the result. That surgeon who took the patient with the elevated PTT to the operating room faced a higher liability than if he'd never gotten that unnecessary test in the first place. Now, I apologize here because when I made these slides, I just noticed this morning some of my references didn't come through, and when I tried to import them this morning, it wouldn't, but I'll gladly supply a list of references to you. Some of them did. But there's a lot of literature out there on pre-op and pre-hospitalization screening tests, and virtually all of it shows that it does no good. None. And this dates back to the 1970s. You can see that this is a 1975 study. Leonard showed that biochemical screening was of no use in pediatric patients who were coming into the hospital and were expected to be hospitalized less than 1 week. Their biochemical abnormalities didn't lead to any changes in treatment. Routine screening done on 1,000 patients hospitalized on admission, no test produced a new diagnosis that was unequivocally beneficial to the patient in another study. This study by Olson, 1,500 patients undergoing surgery now, randomized controlled study where they had some patients undergo routine pre-op screening and some undergo none. There was no difference in outcomes. Dunbridge, there was no difference in length of stay or outcomes in patients who underwent over 8,300 extra tests during their surgical hospitalization. And NAR, in the Mayo Clinic, looked at 3,000 ASA 1 or 2 patients, regardless of the surgery they were having, okay? And they didn't test them, and there were no adverse outcomes. So what I want to tell you is that a significant portion of pre-op tests that are currently being done are unnecessary, and large portions of preoperative laboratory testing, whether necessary or not, occurs within 72 hours of that window. And what Paige said is very important. You get a bundled payment on your government contractors, but also I have to tell you, your third-party payers follow suit. They often, if they're going to bundle a payment or contract with you, will use that same 72-hour rule. So anybody want to tell me who's paying for that test? You are, because it comes out of your pay. Does that all make sense to you? So what we did in 2009 in my clinic was we reviewed over 500 patients that came through pre-anesthesia clinic. Now this didn't solely include your service. It was orthopedics, GYN, and general surgery. Those are the 3 groups we looked at. And we looked at how many tests were done, and we reviewed every single chart and said, were there any indications in the chart anywhere for that pre-op test, yes or no? And then we also looked at outcomes. So chest x-ray, done with 72 hours of surgery, almost a third of patients had them. The percentage of patients tested who had no indications for the test, 13%. Chest x-ray, I'm not going to go into too much in detail in this talk because many of those patients were general surgery patients who were undergoing oncology procedures, and the indication for the chest x-ray was not pre-op screening, we were doing a metastatic workup. Okay, so they don't quite fit. CBCs, 68% of the patients who got them had no indication for them. Chem panels, 25, 20%. Coag tests, 71% of all patients getting them didn't have an indication for them. And Hep C, none of the patients had an indication for that. I don't know why you're doing that test. And I've called infectious disease, and I've called the hospital injury people to see if there's any benefit to you having a patient screened ahead of time, and they said, no, we don't understand why they're doing them, and we wish they would stop. Okay. Do you routinely order a screening EKG prior to surgery? I want to take 2 simple tests, EKG and coag screens, and walk through them really carefully with you so you can see the cost and medical implications of this. This is from a study in the American Journal of Cardiology in 2006, so it's not a very old study. Over 28,000 surgeries in 23,000 patients. A quarter of the EKGs were done were abnormal. And yes, the abnormal EKGs were associated with an adverse mortality. The problem with it, there was nothing you could do with that test. It didn't lead to difference in testing. It didn't lead to difference in outcomes whether you did it or not. So you did identify a higher risk group, but you took no action. The people in the study, took no significant action and could take no significant action to benefit the patient based on that study. Adding a EKG to clinical risk assessment and type of surgery did not improve prediction, did improve prediction of cardiovascular deaths, but only slightly, and did not change prediction in patients having lower intermediate risk surgery. So anyone who's having lower intermediate risk surgery, and in your department, that's anyone not having a total hip or a multi-level spine. All of your other surgeries are low and intermediate risk. Didn't help, so you might as well not do it. And the absolute difference in risk, you always have to say, well, yeah, the study says there's a statistically significant difference in risk. But the next question you need to ask when you're reading that article is, but what was the absolute difference? It might be that, yeah, I can find a statistical study that says that the p-value is 0.05, but it only affected 5 patients. It may not be worth doing on a cost basis. The absolute difference in risk between those with abnormal EKGs and those with normal EKGs was less than 0.5%. So you're not making a very big difference, and you're costing the patient $200 a piece to get that test. This is 200, when you looked at patients who were just over age 50, let me remind you, that this was lots of surgeries over 15 years old. But when you took patients over age 50, you're going to say to yourself, those people have a higher prevalence of disease, right? You remember your basic epidemiology? My screening test should be more effective then, have a higher true positive and a lower false positive rate. Basic epidemiology. 45% of those EKGs are abnormal. So rather than 25%, the test negativity or the test positive test results go up. They found lots of right and left bundle branch block, which we see in my clinic all the time. Those are associated with increased morbidity and mortality, but there's nothing you can do about them. There's nothing you can do about them. They're just a fact of life. And the presence of bundle branch block was actually not a better predictor than using the revised cardiac risk and index factors alone, which you can do by simply asking the patient the question rather than doing the test. So, what about doing a baseline EKG? This is the argument I face in my department all the time. My anesthesiologists, the ones who haven't read the literature, say, oh, but I need that baseline to compare it to. The fact is, studies show that a lot of them are never looked at, and baseline EKGs in the 1987 study had no impact on management. And the American Heart Association will tell you if you have an intraoperative or postoperative event, the baseline EKG makes no difference. You do a 12-lead and a set of troponins, and that's what you're going to base your study on, or your further workup on. So let's think about this cost for a minute. I want you to try to get it in your head what we're talking about in terms of cost. Low to intermediate risk surgery. No, and let's take a patient who has no revised cardiac indices, regardless of age. You got that 94-year-old. He doesn't have cardiovascular disease, cerebrovascular disease. He's not on insulin as a baseline drug. He doesn't have a creatinine greater than 2, and he doesn't have he doesn't have a history of CHF. Those are the 5 factors. The risk of any major cardiac event in that patient is less than 0.4%. This is very low risk. It's almost the risk of the baseline population, all comers greater than age 15. The cost of doing EKGs on just 250 such patients, I took some round numbers to give you an idea of cost, is about almost $19,000 at this institution. For $200, you can do the troponin set and the EKGs on 94 patients for the same cost. Okay. Now, that would if you look at the numbers, I'm saying if a third almost of your patients had intraoperative cardiac events, you could do the right testing on them for cheaper. And as I tell people in my department, I sure hope that half a third of the orthopedic patients aren't having MIs intra-op, right? It's going to be really less than 1%, less than 1 in 100. But even if we assume that 10% of the patients have those suspected things, if we don't do pre-op EKGs and reserve our post-op, appropriate post-op testing for diagnosis, we save over $13,000 for every 250 patients. That's just one test, okay? So by actually doing the appropriate test, post-operative, avoiding the unnecessary pre-op test, our UW guidelines, well, the ASA says, the American Society of Anesthesiologists says there's no real criteria. It's up to you. Because they know, they've reviewed this data and they agree with what I said. We don't have any testing criteria. We ask for an EKG if none has been done in the past year for all patients who have comorbidities and increased cardiac risk, and for over age 65, only for patients undergoing non-low-risk surgery. And that's the criteria that Paige just stated. So we don't order an EKG on the vast majority of patients, even when they may have cardiac comorbidities, because most of them have had an EKG in the last year, we don't have to repeat it. If I were queen of the OR, and I'm not, I would order no pre-op EKGs. But that gives my colleagues a little bit more, because they haven't read the literature. I want to take coag studies, because this is an expensive one, and it makes no sense to me whatsoever, because this is one of the best studied pre-op tests in the world. We know how this behaves. We know that screening coag studies do not predict intraoperative bleeding. They do not predict intraoperative bleeding. I'm not even going to say the studies suggest that it doesn't predict intraoperative bleeding. The studies show they do not predict intraoperative bleeding. But let's look at some numbers. In that case that Paige presented, we can ask, what's the most common cause of an elevated PTT? Well, it's lupus antibody in about 53% of cases based on some pre-op. This is a pre-op study group. And anti-lupus antibody is a procoagulant. It makes you clot. It doesn't make you bleed. You can't find a cause in another 32%. There is in one large general surgery study a demonstration that about 4% have a factor deficiency that might predispose to hemorrhage. The problem, that same study showed that nobody bled, and they were having major surgery. So while they might have a factor deficiency that you could find, it's a minor factor deficiency, and it doesn't lead to bleeding. As I'm fond of telling people, and some of you in the audience have heard me say this, if your patient bleeds, if we do a verbal coag screen by asking some questions, and they say no to all the questions, if your patient bleeds after surgery, it's because you're not bad. Okay? That's why they're bleeding. This is from a 2005 study, by the way. As Paige mentioned, most abnormal coag tests in GYN oncology patients, these are due to known risk factors in 3.4%, 48.4% have elevated fibrinogen, 27.3% have elevated D-dimer, 58.4% have at least one abnormal study on a coag screen, most of which predict clot, not bleeding. So, these are a bunch of studies, and they are by no means exhaustive, of all of the studies on pre-op coag screening. So, in these studies here, we're looking at over almost 32,000 patients that were studied. So it's a big group. It's a big group. Tests in patients who did not have risk factors on physical exam or on a questionnaire, which I'll show you in a moment, were unlikely to have abnormal tests, and when tests were abnormal, they did not predict intraoperative bleeding. So they were no use. Screening. I'll come back to the questionnaire in a moment. So what did we do here at UW? Well, we looked at patients here. At least some of you did raise your hands about wanting those coag screens. Thank you for being honest, because almost 40% of people at UW are these. 2 patients in this group had actual indications for coag studies, meaning that one patient was on anticoagulation and the other patient said, I bleed easily. So we did them. There was only one abnormal test, and that was the patient who was on Coumadin. Who'd have thought? And in 100% of the screening studies, meaning those that were done in patients without indications, there was not a single abnormal test. Estimated total charges for these 38 tests alone, over $8,000. You can actually say to yourself that one patient had a very expensive test. Because to detect that one abnormality, which we knew would be present, because she was on Coumadin, we spent $8,000 looking at other people. Charges for indicated testing were only $450. If we restricted our testing only to the 2 patients for which there was an indication, it wouldn't have cost nearly as much money. If we amortize this over all of the testing in those 3 surgery groups that we see in PAC for a year, the cost is $1,000 cost would be $66,000 for an annual savings of almost $1.2 million. That's in our clinic for only 3 surgical services, one of which is you. What is the pre-op assessment tool for coagulation? You ask 5 questions and you look at the patient to see if they've got bruises. Okay? And the 5 questions, I ask my residents this all the time, and they miss the most obvious ones. Do you have a bleeding disorder? Does anyone in your family have a bleeding disorder? Are you taking a blood thinner? Right? Do you have a history of easy bleeding or bruising? And by this we mean you bleed after you brush your teeth for 5 full minutes without stopping. This is not just bleeding around the gum line when you brush your teeth. And do you have a personal history of a disease that would make you bleed more? Somebody with cirrhosis, they may bleed more. So the guidelines are international for pre-op screening for coags. British Committee for Standards in Hematology, 2007. Institute for Clinical Systems Improvement in 2008. ASA guidelines, these were 2003. Sorry, I'm going to come back to that one. All of these say, ask those 5 questions, look at the patient, see if they have bruises or TPI, and if the answer is no to all of that, do not do a pre-op coag screen. If the patient bleeds, it will be fish cutting. Now, I want you to say, yeah, that's everybody else. But we don't do that because not everybody in this room raised their hand about coag screens. So I want to show you what you're doing. This is our data. The blue is you, and the red are other institutions around the United States, most of which are academic and of comparable size. You guys are way, way up over your peers in terms of how many tests you're running. Look at this, Hep C panels. There's no reason to ever do a Hep C panel prior to surgery. You're doing them in about 37% of the patients. Everybody else? Where is it? Way down there at 5%. Should be 0. So some of the other institutions have some education to do too. Let's look at platelet count. I use this as a surrogate for a coag screen because they didn't do a full one. But platelet count here is being done in only 2% nationally. You're doing it over 25%. And these are screening tests, not targeted tests. I have no argument with you if you say my patient bled for 5 minutes after brushing their teeth and I'm going to get a coag screen. That's a targeted test. But we're going to coag screen on everybody that's a screening test. So my philosophy about pre-op testing, and I hope you take it away, and I hope you think about it, and I hope you take it to heart, is what Mies van der Rohe said. Now, he was a mid-century architect. He did these beautiful houses, very simple in design, glass, streamlined. This is Farnsworth House in Illinois. You can go see it. It's a kind of a park. It's beautiful. And what Mies van der Rohe said is, less is more. Thank you.
So I'm just going to talk a little bit about what we've been working on and our goals and how we're going to proceed over the next 3 to 4 months. And so I think you get the point that we really are trying to reduce the number of unnecessary primary tests we order. So those are the tests that we just are reflexively ordering for our preoperative patients. And then hopefully we'll decrease the number of secondary tests that we're ordering to actually follow up on these spurious abnormalities we're getting in our primary tests. I should emphasize, this is for elective orthopedic surgery. And so this doesn't necessarily apply to Haverdu. It doesn't apply to all of our patients here. But it applies to the vast majority of patients orthopedic patients that we operate on at this hospital. We're going to try to make sure that we are getting these tests done early enough so they don't fall within that 72-hour global window, so we actually get paid for ordering them. So first we want to minimize the number, but if we have to get them, we're going to try to shift those up and make sure we get them early enough so that the hospital is reimbursed for them. We want to do all of this in a way that we're not going to increase OR delays or cancellation rates. I know that's something that we're all dealing with for various reasons, and we don't want this to contribute to the problem. We're also going to carefully monitor our outcomes, make sure that none of the postoperative complications that we encounter are things that would have been avoided by having some of these tests done preoperatively. And again, we're sort of being hyper vigilant. I think Dr. Van Nomen makes a compelling argument that if you look at the literature from around the world, you know, we really shouldn't be hurting our patients by decreasing the number of these tests. We should actually be helping them. And finally, we want to avoid the complications of over testing. So we are gathering data from the Center for Clinical Excellence to look at our testing behavior over the last 5 years. And we're going to stop short of basically today to avoid any potential Hawthorne effect, because I'm hoping that everybody who's heard the talk is going to leave here and think a little bit and maybe order fewer studies, you know, as soon as they start practicing later on today. So we're going to collect the data. We're going to look at a number of specific tests, particularly the ones that don't have a lot of support for ordering them. We actually do pretty good job with chest x-rays, but from our preliminary look at the data, we think we have a lot of work to do with all of our blood work, EKGs, and really there's no indication, as we've said, for hepatitis B, C, or HIV screening. So these are the things that we're going to look at. We are going to encourage feedback. There's no intent to force this upon everybody. I hope at the end of the process, before we go to rewrite our CPOE orders, that we'll actually have concurrence, group concurrence, as to how we want to proceed, and hopefully be able to standardize the order sheets that we have, or the electronic ordering process that we have. We're going to have guidelines posted by all the computers where people are likely to order things. We're working on modular pop-up boxes, and so if you order coags, you might get a little reminder that instead of ordering that lab, all you have to do is ask the patient those 5 questions that we've outlined. So we're going to try to not make it any more cumbersome. We all realize that CPOE, either it's a learning curve or perhaps it's always going to be a little less efficient than checking a box off on a sheet of paper, as most of us have done for most of our careers. So we're very cognizant of that. We don't want to make the ordering more difficult. We know that it falls primarily upon the residents and the PAs, but we are going to have certain reminders and guidelines associated with our order sets. And the default is going to change from having long lists of things where you just check them to basically making people work a little bit, not a lot, but work a little bit if they actually want to go ahead and order some of these things that are typically not indicated. So we don't want to waste your time and make the process more cumbersome, but you are going to have to do a little bit of work to get these labs ordered. There are other processes going on in the hospital where people are also looking at ordering blood products for surgery, and you're going to see some of the same things happening when we go to order typing screens and typing process. So again, this is just a very brief summary slide, and you can take a look at this, but most of these labs, there's very specific criteria for ordering them. Most of the surgery we do and most of the patients we treat at this hospital don't really meet these criteria. And so we played around with the numbers a little bit, and of course all of this doesn't directly come back in cost savings and profit to our department. But when you look at this, we really anticipate potentially being able to save millions of dollars a year. And the hospital is interested in this process. The chief of staff is interested in it, and it's probably going to eventually be rolled out to the other surgical sections after we pilot it here. So we're shooting for, to have these order sets implemented sometime in the fall. We'll start looking at the data after 3 and 6 months, looking at how our behavior has changed, looking at postoperative complications, looking at delays in getting patients to the operating room, looking at changes in reimbursement. And we've secured some financial support to actually have help analyzing all of this data. And hopefully sometime by the middle of next year, we'll be able to look back and I hope we'll see some radical changes in our lab ordering, some major improvements in reimbursement, and along with that, we will not have ended up harming our patients at all and maybe helping. And so all three of us now will take some questions.
Okay. I was wondering if any concurrent changes to the patient filled out, physicians reviewed, like review of the systems form that patients often fill out are going to be changed, maybe grouping some of the questions that would relate to an indication for an EKG or coag screens might be grouped just to kind of have it be a little bit more of a checklist to make sure that those important screening questions get asked a higher percentage of the time rather than just by a physician or PA remembering it each and every time.
I think that's a good question, and while we haven't specifically addressed those, as we go along, we sure can. As you point out, even though many of those questions are already present in your data or in your screening tools, having them grouped together so that you can logically draw some conclusions from them are important. And we've certainly done that in some of the cases. So we haven't specifically addressed that, but I think it's a good point for us to think about.
I mean, the education side of it is interesting because this data is not new. And I spoke to one of my partners who said 15 years ago they were worried about this when, during when she was in medical school. And I actually can think back longer ago than that, and we were talking about the exact same issues. And that was over 20 years ago. And so I think a lot of it is just cultural, how do you change the culture and how does the information get passed down from group of residents to group of residents, year to year. And so I do think, this sort of education, but we also do have to have these checklists and order sheets. And again, I along with that, we have to just keep it simple. We don't want to increase the time it already takes to do this pre-op ordering. I think Darren was next.
Thanks. That was a great talk. A lot of very interesting data on the unnecessary tests and that. One question and then one comment. The question was that table that you presented comparing here to other centers. Kind of impressive, discouraging, a bunch of things all at once. And the question I had is those other centers, what was their setup around perioperative time? So were those patients in other places screened by anesthesiologists, by internists, by their primary care doctors? Some other places I worked, every single patient would be seen either by an anesthesiologist or an internist, and they would decide what preoperative test they need done. And the reason I asked is exactly what I was just saying, because data's been there for a long time. I'll freely admit, and yes, there's other people in the room in the same boat that don't know all that data. It's hard enough to keep up to date on the literature on what you do day to day, let alone everything else.
I have a brief comment, and then we'll let Gail. So when I was talking to John Lane about this stuff, who came from the University of Alabama, and that's the exact system that they have there. Every one of their patients basically gets worked up in a pre-anesthesia clinic, and all of those decisions are made by the anesthesiologist. But there has to be buy-in by the surgeons to give up control of their patients to do that. And I can't remember if that's one of the places like the Mayo Clinic where there's no inpatient, orthopedic service per se, where we're just consultants. But I think that kind of system would be great, but you have to be willing to seek control of your patients. To do that.
I'd say the same thing that Howard did, and then from the institutions there in that slide, I can't answer that question directly, but I can give you a sort of side answer. which is that it has been well studied in both Canadian and American systems that use a pre-anesthesia clinic in which an anesthesiologist is in charge of ordering the tests. That there's an immediate cost reduction in 25% in pre-op testing with no uptick in post-operative complications. There are proposals nationally to the national healthcare system to help set up what we call perioperative hubs in various institutions around the nation where you would do exactly that. And you would have an overall pre-op clinic, generally run by anesthesia because they're sort of the last step. You have to add these on. And that they would do evidence-based testing only. The problem is exactly as Howard said. We're happy to do it, actually. I'd love to expand the pre-op clinic to take care of evaluation using pre-op testing and all that. Seriously. But I've got to have a surgical buy-in in terms of having the surgeons agree that they trust us to do that job well and to do it appropriately for them. And that means we actually have to do that job well, number one, and be able to show that. But then also we have a big change in culture for women. So you have exactly pinpointed an area that nationally people are very interested in.
So I think Myth had a question, Dr. Quato and then Dr. Lee. So Myth.
I actually had a similar question about Davidson, but you're kind of touching upon the disconnect between the anesthesiologist and the intraoperative anesthesiologist as well. How are you guys addressing that? Say, this is the level of testing we anticipate, and then the patient shows up in the day of the OR, and they're like, hey, we need a PT9R, we need to test X-ray, maybe EKG, and delay cases. Are you guys getting a police message in the anesthesiology department about this?
Yeah, and part of this project, it's an excellent question because we are absolutely contributors to this problem as well. And I face some of the similar issues with convincing my own colleagues that pre-op testing is needed less. And the answer is we've already undertaken some of this. In the last couple of years, we've developed pre-op testing advisories for our department that we have been following and nobody has and that we presented and got to faculty at UW and Harborview, and that we got buy-in from, and we've gotten very little pushback from. We still occasionally have a new provider come into our system who says, oh, the patient didn't have an EKG on delay, and when we get feedback on that, believe me, we'll come down on it. Part of this project will be to take the advisories that we have codified, most of which we've pretty much done already, but we're actually now putting into references and evidence based on, present it to both faculty groups and say, look, this is the new standard, and get buy-in on it. We're going to do the same with you guys. We're bringing them back to you for feedback and buy-in too, so that we can all agree on a set of standards and that you should not see that problem, and when you do see that problem, we have a tool to go back and say to that provider, you're not a solo practitioner, we have a practice-based agreement on this, we do not want delays for these reasons. So you're very right, that's what we have to do in this system. So.
Yeah, I mean, we've looked at this when we were at home when I'm in New Zealand, and trouble with establishing a pre-op anesthesia system is that comes at significant cost. So the cost may be shifted from testing. And the problem you get is the patient that sees you, the doctor that sees your patient in their clinic is not the doctor that puts your patient to sleep and doesn't necessarily follow the same criteria. In fact, there's very good evidence for that the less doctor the patient sees, the more likely they are to get through without a complication. And so having pre-operative anesthesia assessment creates a whole other battery of problems and another battery of costs. In fact, there was a study by a guy called Sid Day. He was just family of Greek immigrants to Australia, and they embraced Australia so much. His initials are for Sydney, Melbourne, Adelaide, Nave, which was Chris Mahia. He did a study, and the only test you could prove you needed to do in patients over the age of 60 was a potassium. And that was it. That was the only thing you'd find an abnormality with that you could make a significant difference.
Well, first of all, I want that study that says the less doctors you see, the better, because that's what I tell everybody. Stay away from doctors, they hurt you. But some of what you're saying may be system dependent, because we do actually know from studies in some North American clinics that we save dollars. But what we do is we offshift some of the costs in the surgical pre-op testing, use some resources there. You may or may not know that pre-op assessments in general for patients are not billed separately by anesthesiologists. So you get the trophies and everything for free here in the U.S. You don't get an extra charge for the physician's involvement. So I hear you, and and that is an important consideration to think about, but it doesn't hold true through all of the studies that are out there on preoperative assessment, particularly pre-op anesthesia clinics. So before I can answer that more directly, I've got to look at what your system looks like.
Last question, I think, was Mike.
I had the same question as Smith, so.
Okay. Doesn't anybody have a question